Good morning or afternoon, everyone, and thank you for joining us for our session today. My name is Kristen Reed, and I am a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. Today we'll be discussing the effectiveness of internet interventions providing personalized feedback for weight loss in overweight and obese adults. Our presenter today is Dr. Anna Haste, a research associate at Newcastle University. We would like to wish a warm welcome to our Health Evidence users, as well as those joining us from the KTA Cancer Prevention Study. Throughout the session today, we will be posting polling questions through the WebEx platform. Your participation in polling questions is voluntary and anonymous. We hope to enable engagement and stimulate discussion throughout the session. So I will just leave this content slide up for a moment and then move on shortly. So just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within the next week. The links to those resources will be posted in the chat section. Today, we are very excited to be talking about a systematic review and meta-analysis of internet-delivered interventions providing personalized feedback for weight loss in overweight and obese adults. The link to the Health Evidence Review page for this systematic review will be posted in the chat section. You can click on the link and follow along in the review using the PubMed link out. Just a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions or comments. We ask that you send your questions or comments to all participants and not just to the host. Also, please feel free to post your questions and comments throughout the session. Towards the end of the session, we will save some time for the presenter to respond to any questions or comments that you might have. For the best connection, we recommend you use a wired internet connection versus a wireless connection, and should you have any issues, we have posted the 24/7 WebEx helpline on this slide as well as in the chat section. For your audio today, please listen through your speakers. If you're having trouble hearing, you can go up to the top under Communicate at the top bar in the WebEx platform and then click Audio Broadcast. So we have our first polling question for today, and we're really just wondering how many people are joining us in this session. So whether it's just yourself, 2 to 3 people, 4 to 5 people, 6 to 10, or over 10 in your group today. Also, please make sure to press the Submit button after you've selected your response. So it looks like coming in right now, most of us are joining by ourselves today, with a couple people joining in small groups. We would also like to give a special thanks to our Health Evidence team who works to bring this session to you today. There is a large team of us who will work to keep Health Evidence current and maintained, as well as to coordinate your monthly webinar series. So for those of you who are not familiar, Health Evidence is a service and research organization involved in KT for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews, where we provide over 5,000 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of Health Evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. So really the value add for using Health Evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. We have also done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our ratings for each of our 10 assessment criteria. Health Evidence website also has various tools and supports for EIDM available online, and many of our users have informed us that our tools and repository are both easy and simple to use. So I'm just going to quickly touch on the model for evidence-informed decision-making, which we can keep in mind as the presenter goes through this systematic review today. This model consists of 5 components that you can see in the diagram. Traditionally, public health practitioners and decision makers consider evidence about community health issues in local context, existing resources, and community and political climate in making decisions about programs and policies. However, it has become apparent that considering evidence about research can be challenging to integrate into public health practice. As such, the Health Evidence webinar series is designed to identify relevant research evidence for public health decisions. On this next slide, we can see the stages of the evidence-informed public health process that helps to illustrate the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. There are 7 steps outlined here, and today we'll be focusing on how the presenter has worked through the first 4 of these steps in order to help public health practitioners with the remainder of the steps in this process. So just another polling question that we have for you today, and we are wondering how many participants here today have heard of or are familiar with PICOS. So while you continue to answer that question, we do have quite a few people that are familiar, but a couple that have not heard of PICOS before. So for those of you who aren't familiar, PICOS is a way for you to structure your research questions. It involves defining who the population is that you're interested in, what the intervention program or service is that you want to know about, the comparison group, if any, and outlining the specific outcomes you are looking for. Sometimes we also have a particular setting in mind, which we can also state in this question form. So for example, school or community setting. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which then allows you to further articulate specific components of the question and can help you to search for relevant information related to your PICO more easily and efficiently. So I'm going to move on to our next polling question. And what we're looking to ask actually is how often do you use systematic reviews to help inform your programs or services? So always, sometimes often, sometimes or never, or you might not be familiar with what a systematic review is. So we're seeing that many people actually always or often use systematic reviews in their work, as well as some people that sometimes or never use. So it's a nice variety of responses. I'm just going to move on to the next polling question, which is the last polling question before we get started. And really what we're trying to do is ask a question that's relevant to the topic area before the presentation. So we are wondering what your agreement is with the following statement. So do internet interventions providing personalized feedback are effective for weight loss in overweight and obese adults? So I will leave that open to you while we get into our presentation. I'm seeing here that some people are agreeing, some people are not too sure. And I really thank you for your responses. So I'll move on to introduce our presenter while we finish up that polling question. And we're really excited to have Dr. Anna Haste, who is a research associate at Newcastle University, joining us from the UK today to present on this systematic review. So without further ado, I'll pass it along to Anna, and thank you very much for joining us today, Anna.
Okay, so hello. Thank you for the introduction there. So I work at Newcastle University in England. I'm a research associate and I'm also a chartered health psychologist. And today I'm going to present on a systematic review that I conducted during my PhD, which I finished 2 years ago now. And just to note, that's why the systematic review is actually published under my maiden name, which is Anna Sherrington, so that's why the change in name. So the systematic review is entitled Internet Interventions Providing Personalised Feedback for Weight Loss in Overweight and Obese Adults. And the reason that the systematic review came about was actually my PhD was looking at to evaluate an internet-based weight loss intervention, and this involved dietitians and exercise experts in England providing feedback to NHS patients via the form of a website. So the aim of the intervention was to try and see how this would be accepted and whether it was feasible within an NHS setting, and whether the patients would actually accept it as a form of healthcare. The way that I looked at this was actually conducted a pilot RCT and a process evaluation, and the results of that have actually just got accepted in the Journal of Medical Internet Research Diabetes Journal. But one of the reasons that we decided to do a systematic review is to try and identify what was already being conducted in this area, and also the effect of feedback itself. So one of the main aspects of the intervention that I was conducting for my PhD was the use of dietitians and the use of exercise experts via this medium of the internet, via a website. So we thought it was key to identify what information was out there and how effective this method of delivery was for providing weight loss for people. So I'll just move on to my next slide. So that's just the title, as I've mentioned. So why did we choose to look at overweight and obese people? So I presume many of you will know this already, but Public Health England actually conducted a survey in England a few years back now, and it identified that 6 out of 10 men are actually classified as obese or overweight. So a large majority of the population, and also more than 5 out of 10 women. And this actually works out as approximately a quarter of the population being classified as obese, so with BMIs over 30. So it's obviously an issue. It affects a lot of people in England. And why is this a problem? Again, many of you might know this or have heard things about the problems with obesity and its connection with a series of different diseases, and not just physically, also mentally, so things like cancer, type 2 diabetes, depression, and even premature death. So findings in previous research have identified that a higher BMI can result in a higher risk of disease. So therefore, healthcare needs to try and intervene to stop these health conditions becoming apparent. So I'm going to mention internet-based intervention quite a lot, so I thought it was just worth noting down a few of the things that involves when I mean internet-based intervention. So it's usually a software system, so it usually takes the form of a website like it did with my study. Participants are usually required to log in to access it. And it normally takes the form of providing lifestyle information, so things such as articles or recipes on diets or physical activity. It can take the form of modules or assessments that participants are required to work through. Self-monitoring tools are available that participants can enter either any physical activity they've done or any diet intake. Systems can be interactive, so there's a possibility of participants interaction with each other, and this usually takes the form of either chat rooms or discussion forums where people can post topics. And one of the key things that we're looking at today, personalised feedback, and this can actually take the form of either automatic feedback, which is usually an algorithm that's been set up, so whenever a participant enters any information, based on the information that's entered, an automatic feedback response can be provided. And the alternative is a human personalised feedback, and this is usually a researcher or a healthcare professional providing feedback based on participant input. And as I've mentioned, participants can engage with each other, so they're able to chat through the website and in the forums, as I've mentioned, chat rooms or discussion forums. Okay, so what's the rationale for using an internet intervention for weight loss? And what has been found in previous research is that traditional primary care treatments, which are usually within the NHS in England, it usually takes the form of either GP appointments or group sessions or one-to-one sessions with a dietitian. And what has been found in some of the previous research is that it can be quite costly. It has mixed effectiveness, and there is problems with actually keeping people and retaining people in the interventions. So it's been acknowledged in a previous systematic review that there is a need to look in further depth at the actual components, individual components that are involved in interventions. And 2 previous systematic reviews actually identified that personalised interventions have been shown to be more effective. So internet weight loss studies have increased dramatically over the last decade, but there is still a lot of areas that remain unknown, and there has been findings to show that there is potential to reduce healthcare professional input and time per patient, but there are still mixed findings in this area, so more research is needed. Okay, so the research question from my systematic review was, how effective is individualised internet-based feedback compared to those receiving no feedback within weight loss interventions for overweight or obese adults? Okay, so this is the PICOS that Kirsten mentioned, and the inclusion criteria for my review was looking at adults, so we looked at people who were aged over 18, and we were looking at overweight or obese adults, so they had to have a BMI of 25 to be included. So the interventions themselves needed to either target diet, physical activity, or both for weight loss, and they had to be at least in part delivered individually via the internet. And what I actually identified within my systematic review was that all of the included studies actually targeted both diet and physical activity. In terms of the comparator group that we used, this was looking at standard care or alternative interventions, but the key thing here is that they didn't include individualised feedback via the internet. The outcomes that we looked at, and that I'm going to show you some results on today, was weight loss, waist circumference, BMI change, and 5% weight loss. And the type of study that we looked at was randomized control trials, and the setting was via the internet. I've popped a link on there for you. This is a site that we have, and it's based at the University of York, and it's Centre for Disseminations, and it allows you to actually register your protocol for your systematic review, and it just means that as soon as you start in a systematic review, you can actually register that it's taking place, and hopefully then it wouldn't be replicated by somewhere else. And the link actually takes you to the proposal that we actually submitted there. Okay, so I'm going to be talking a lot about feedback today, so I thought it was worth putting the definition on that we actually used in the screening process to include or exclude studies for the systematic review. And this is from Nikki et al., and this is from the Calorie Behaviour Change Taxonomy paper. And definition here was provide feedback on performance, and this involves providing the participant with data about their own recorded behaviour, so as I've mentioned, things like inputting their diet or physical activity information, or commenting on a person's behavioural performance, so in terms of them setting a goal, did they achieve the goal and how didn't they, so looking at aspects in relation to their behaviour. So a couple of examples, just so that it puts it a little bit in more context for you. These are from 2 of the studies that were included in my review. An example here is that weekly feedback was given from a pre-programmed computer that instantaneously returned tailored feedback on a website. And this was when the weight loss diary was submitted by participants. And this is an example, as I've mentioned, a type of automatic feedback. In comparison, Morgan et al. At the bottom, actually this is a human-provided feedback, and the feedback was provided to each participant who provided diary entry, and they received up to 7 of these over the course of the intervention, and these were provided by the research team. And the feedback was provided in terms of strategies to try and address weight loss, reduce energy intake, and increase energy expenditure. Okay, so in terms of how we identified the studies that are included in my review, we used the following search strategy. So we looked in a range of different databases, looked through clinical trial registers, and also hand searched some relevant journals, conferences, and thesis databases. And this provided us with a vast amount of papers that were identified through the search terms that we inputted. And what we ended up with was 14 included articles, and these were actually 12 different studies. So 2 of the studies had actually published 2 papers each. So we had 12 studies that were going to be included in the review. Okay, so moving on to the results. So the way that I looked at the results was to compare feedback intervention groups versus control groups that provided no feedback to the participants. And just to give you an idea of the variety of different control groups that we actually identified in these studies, as you can see down the left-hand side, the control group split into 2 different approaches. So there was the minimal intervention, so this was either treatment as usual, a waiting list, or took the form of a leaflet about healthy lifestyle. Or there was actually 3 of the studies that used control groups that provided a website, but the participant could input into the website, but they provided no feedback back to them, so it wasn't an interactive form. This table is also here to show you the different time frames that we identified. So the total just means every study that went to, we analysed the studies looking at the end point of each of the interventions, and I'll explain that again when I'm going through the results. But what we also identified was that studies tended to vary in terms of how long they lasted and when they collected data, and these emerged in the form of 3, 6, and 12-month periods. So the results that I'm going to show you, so I'm going to go through some forest plots that we identified through the analysis that I conducted, and these are going to be ordered by effect size, so the most effective down to the least. In all of the continuous outcome measures, we use mean difference between the groups, and in terms of the dichotomous variable, the 5% weight loss, we used a risk ratio for this. Okay, so the first result that I'm going to show you is looking at our main outcome, which was weight loss, and this is in kilograms. And the endpoint just means the end of the intervention for each of the studies. And what this actually shows you is that there was a significant difference between the intervention groups and the controls. So those that were provided with feedback were losing significantly greater weight loss than those in the control. And this, if you look down the mean difference column, was actually a difference of minus 2.13 kilograms. So the intervention group were losing over 2 kilograms more than the control group. So I'm now going to show you this at the different time frames, and apologies that there is a lot of information on this slide, but it was just to show you the difference of how the studies differed in terms of the time frames that the interventions lasted for. So this shows you 3, 6 and 12 months, and as you can see, the smallest amount of studies actually lasted for 12 months. And what we identified was that by 3 months, the intervention was more effective than the control. At 6 months, the interventions were more effective than the control, but actually by 12 months, there was no longer a significant difference. So by 12 months, the studies that lasted that long, the interventions were no longer significantly losing more weight loss than the control. They were still losing more weight loss, but it wasn't a significant difference anymore. Okay, so I'm going to move on to the next outcome measure, which is BMI change. Again, looking at the end of the intervention for each of the studies, what we identified again was that there was a significant difference. So it was shown that the feedback group had a significantly greater impact on reducing BMI in the participants than in the control group. And again, I'm going to show you the split against the different time frames for this. But the difference here from the weight loss one is that actually for BMI change, there was a significant difference throughout. So this remained significant by 12 months. So a difference here between the different outcomes. Okay, in weight loss, waist circumference is also a key factor that is important in terms of health benefits. So we looked at this again for one of our outcomes and identified again that the intervention groups were significantly, were losing significantly more around the waist than those in the control group. And what we identified here was that they were losing just under 2.5 centimetres more in the intervention group around the waist circumference than the participants in the control. Okay, and again, I've shown you the different time frames, and what we identified here was, again, you can see that there's the least amount of studies in the 12 months. And what we identified was that at 3, 6 and 12 months, the intervention groups were all significantly losing more in terms of centimetres around their waist than the participants in the control group. And the final outcome that I wanted to show you was 5% weight loss. Now this is recommended that participants try and lose 5% of their initial body weight in terms of trying to provide the participant with health benefits and reduce their risk of disease. So we thought this was a key outcome to look at. Again, what we identified was that the intervention group were losing, the intervention group had a higher amount of participants achieving the 5% weight loss than the participants in the control group. And in the risk ratio column, in the last number is 2.13, and what this signifies is that those in the intervention were actually twice as likely to lose 5% weight loss than those in the control. So those participants who were provided with feedback via the internet were twice as likely to achieve this 5% recommended weight loss than those participants in the control. And again, just the last one in terms of the different time frames. So we looked at 3, 6 and 12 again, and we identified that at 3 and 6 months, the intervention participants who were receiving feedback had a higher proportion of the participants achieving 5% weight loss, but actually by 12 months there was no difference, no significant difference, sorry. So what we identified was that the the weight loss and the 5% weight loss. And I'll show you this as a summary of all the results that I've gone through, because I appreciate I've showed you a lot of different forest plots there. So this is the summary of significant results. And what it shows is that the only two that weren't significant were the 12 months, and this was weight loss and 5% weight loss. What we thought this was important in showing us was that actually there was a small amount of the studies that actually were lasting as long as 12 months. And this provided us with the recommendation that more research needs to be done in the longer term. But also what we identified was that actually one of the studies that was conducted up to 12 months that was weight loss and 5% weight loss outcomes actually had one of the control group that outperformed the intervention, and we think this may have impacted on the significant levels. But we thought that was important to look at the different timeframes, because it actually identified to us that longer term research needs to be done in this area. Okay, so coming from a health psychology background, I was interested in some of the behaviour change techniques that were included in the interventions. So although the strong focus was on providing feedback on performance, one of the things that I was very aware of was that other techniques are included in this type of intervention, and that for weight loss is a variety of different approaches that are used. So what I actually did was I went through the included studies and tried to code the different techniques that were included in the interventions. And what this actually emerged was some of the most commonly used were the ones that I'm showing you here on the screen. So as you would imagine, the most popular one was providing feedback on performance, but there were other techniques used, such as providing information on consequences, and self-monitoring, which I've mentioned before, of behaviour. So this is the participant either inputting diet intake into their website or entering how much physical activity they've done. Or they could self-monitor the behavioural outcome, which is actually inputting their weight, for example, or their waist circumference. And this wasn't a surprising behaviour change technique to find, because in terms of to be able to provide feedback to a participant, it's very important that you gain information on their behaviour and their behavioural outcomes. In order to provide accurate and personalised feedback, you need to know what they're consuming and what they're actually doing in terms of physical activity. Another one that was commonly used was social support and social change, and this is in the form, as I've mentioned previously, in terms of the chat rooms or the discussion forums, but actually going outside of just relying on the feedback that was given, but actually trying to get interaction from others and learn from how others were conducting their approach to weight loss. And finally, one of the other more commonly used techniques was goal setting, and this tended to be either in terms of the behaviour or the outcome, as I've mentioned. So they were setting things like, I will achieve my 5 a day of fruit and vegetables for behaviour, or they were setting a weekly goal for how much weight loss they wanted to lose in terms of an outcome. So bearing this in mind, I was very aware that feedback wasn't the only thing to play in an internet intervention like this when you're looking at providing advice on weight loss. So what I wanted to look at was the different types of control groups that I've mentioned. And so I'll just go on to the next slide to show you what I mean by this. So as I mentioned, there was actually 9 studies that used a wait list control or a minimal intervention, or a treatment as usual. So this is showing you the 9 studies that actually used this control. And what this identified was that those in the intervention group who were provided with feedback actually lost significantly greater weight loss than the control interventions that were receiving minimal, if anything, advice. And this was very similar in terms of the mean difference to the overall that I've already showed you, because it lost minus 2.14 kilograms. Now, this was not too surprising because the control is very minimal that they're being provided with. But then what I looked at was the 3 studies that actually provided an intervention in terms of letting the participants in the control group have access to the website. So they were allowed to enter the diet, they were allowed to enter the physical activity, they were allowed to set themselves goals. But they weren't provided with feedback, only the intervention groups were provided with feedback. And what this identified was that even when participants in the control group were provided with an intervention, the main difference was the provision of feedback, that those who were provided with the feedback actually lost significantly greater weight loss in terms of kilograms in comparison to the control participants. And this was still just over 2 kilograms of the difference. So those provided with feedback lost over 2 kilograms more than the participants in the control group. So it was, although there is factors to play in a weight loss intervention, it was supporting our suggestion that providing individualized feedback is one of the key aspects to improving weight loss. Okay, so I've mentioned a few different areas there, and these aren't included in my review, and they're aspects that we believe are important and need further investigation in the future. So I'll just go through a few of the ideas that emerged from me doing the systematic review. So in terms of the behaviour change techniques that I've mentioned, I was able to code the ones that were present, but unfortunately the sample sizes in my studies were quite small and there wasn't a huge amount of studies that were included. So I think to extend the scope of the systematic review and to get more studies and greater amounts of sample size actually might be interesting in terms of identifying what behaviour change techniques are there, and also in terms of how behaviour change techniques relate to or impact on effectiveness, engagement with the intervention, and also retention levels. Another suggestion that I'd like to look at in the future is this different type of feedback. So as I've mentioned previously, there is a difference between providing human feedback and providing automatic feedback, and I think it's an important aspect if we are in the ever-increasing ways that we're using technology as to what impacts that actually has on success and engagement. And one of the things that I looked at that isn't included in my systematic review was I tried to look at the different types of feedback, so human feedback versus no feedback, and automatic feedback versus no feedback, and both of those groups actually identified that in the types of feedback they were still significantly more effective at losing weight than the control participants. But one of the things that was interesting was that we actually looked at retention in these two groups, and the human feedback studies actually had a retention rate of around 70%, whereas the automatic feedback groups actually had a much lower retention rate of around 50%. So this is something that I'm very interested in terms of retention rates and engagement with an intervention, because weight loss interventions are known, it's known from previous studies that actually retention is a key issue, and that if people actually stick to an intervention they tend to lose weight, but a problem is with attrition and engagement. And I think this would be really interesting to look into further to see whether this could potentially impact how participants engage with an intervention. Unfortunately, there was only one study that directly compared human versus automatic feedback, and this was Tate et al. But what they found from that one study was that human feedback actually, providing human feedback, in comparison to automatic feedback, the participants lost a higher amount of weight when they were in the human feedback group, but still needs a lot further research doing, but is an area of key interest for me. And finally, although it's really important, as I've done with the systematic review, to look at internet feedback versus controls, I think another area that is really important in terms of practicality and translational research, in terms of how research goes into practice, is how internet feedback actually compares against other modalities. So within our NHS system, if you were to be provided weight loss via a dietitian or an exercise expert, it would, the majority of the time, be face-to-face. So I think what would be interesting is to look at the internet feedback and see how this compares directly with face-to-face feedback. And again, in terms of not only effectiveness, but engagement and retention rates. And I think there's definitely an area that needs further investigation. Okay, so just to conclude, from our systematic review, we can say that incorporating individualised feedback may be a key behavioural change technique for effective interventions delivered via the internet. There's a list of all the different references that are included in my slides. This doesn't include the different studies that were included in my review, but obviously if you went to my review, all of the studies are in full detail in there. And then finally, I'd just like to acknowledge the other co-authors on this study that were involved from Newcastle University, and the funders that allowed the systematic review to be done. And this was provided by Fuse, which is a Centre for Excellence in the UK, and it's made up of 5 northeast of England universities, with Newcastle University being one of them, and their key area is translational research. And we were also funded by an NHS trust as well. So thank you very much for listening, and I'll pass you back over to Kirsten.
Hello, thank you so much, Hannah. That was a really great presentation, and it's really interesting to hear about the potential role of technology in weight loss interventions. So we really appreciate you sharing your walkthrough with us today. As we kind of get into the question and answer period, please feel free to start adding questions to the chat box. While we wait for some of those to come in, I think I would like to move on to the question we asked you at the beginning of this webinar, and just to get your level of agreement with the following statement. So internet interventions providing personalized feedback are effective for weight loss in overweight and obese adults. So we'll give a few moments for you to answer that, and please feel free to post your questions into the chat box. So we are seeing a variety of responses, and many actually are listing as strongly agree or agree. There's still a few people who are neutral, and I think looking to explore this issue further, much like you mentioned, Anna. Yep. In terms of questions, I was wondering that you really looked at and focused on the feasibility of these types of interventions in an NHS setting, and I'm just kind of wondering what your thoughts are on how transferable do you think this would be to other settings, and what settings might that work in as well?
So the systematic review wasn't based on NHS settings, sorry. I just looked at that for my PhD. So in terms of the review, they were in a variety of different settings actually, which was interesting. And I think that it would be, I mean, from my findings from my PhD, I think people found it useful to maybe still have a connection to healthcare professionals, though, because in terms of trust and acknowledgement of the information that they're getting. But I think that's one of the issues that I think needs looking into further, because one of the aspects that I looked at in my PhD was we actually did an initial in-person meeting with the dietitian first, but we didn't do this with the exercise expert, and it did appear to have an impact on levels of trust, or even though that then the intervention went fully over the website. So I think there is something that still needs to be looked into in terms of how you relate to a person if you've never met them before, because I think this could potentially have an impact. But I do believe that an internet intervention would be useful in different settings outside of healthcare, and I think that's shown by the variety of different commercial websites that are out there. In terms of the slimming groups, for example, use websites now as one of their functions, and I think they're used a lot by their members.
That's very interesting. Thank you. Yeah, it's kind of neat to see maybe how that could be used in other settings outside of like healthcare or public health, but also I guess just other countries or other populations. Mm-hmm. Yeah, that's interesting. Thank you. The other thing I guess that I was wondering personally about is did you have a chance to kind of look at or consider in your research the accuracy of participants reporting indicators online versus other formats that I guess are used to collect data for that, so whether it's food or exercise diaries, weekly surveys? Were you able to kind of look at that from that perspective, or was that kind of outside of the scope of the project?
Well, one thing that we were able to do was food diaries with the participants, and we did these as 24-hour food recalls, which there's always quite high risk of accuracy with food diaries. But what we tried to look at was how they entered the food diaries for us as part of the research, but then also in comparison to how they'd entered it on the actual website themselves. But one of the things that we did with the physical activity was we asked the participants to wear accelerometers for certain time frames during the study to see how that compared to the information that they were putting on the website. So the accelerometers are really good because they have a high accuracy, but unfortunately with many cases, like using food diaries, the levels of accuracy of people recording their food was quite low, and for the future is something that we need to look into, but and there are now web-based food diary methods that could almost be inputted into a website like this to use. So I think food intake is always quite an issue to try and get accurate from participants, but I think it's trying to be moved forward in terms of methods of collection. And I think it's moved forward even since I was doing my PhD a few years ago.
That's really interesting. Yeah, I know it's always a bit of a struggle. It'd be really interesting, especially with things like smartphone apps or anything that's popping constantly, and how that could affect that food recall.
Yeah, and actually that was mentioned by some of the participants, because this was, although the participants could have looked at the, sorry, not in relation to the systematic review, in terms of my PhD, the participants were able to look at the website on their phone, but they had to go through a browser. And one of the things that came out very strongly was how much easier it would have been through an app, because then all the data would have been stored on there and they could have just literally just touched it and been logged on. So yeah, even during the course of a year, there was changes that it's that struggle with research that you have to try and keep up to date with technology, but at the same time, you're kind of governed by ethics and what you've submitted as well. So yeah, it was a very interesting learning curve during that.
That's really interesting. That'd be interesting to see as we kind of move forward into a app world, I guess.
Mm-hmm.
So I think I do encourage people, please post any questions that you have in the chat box. So I would just like to take a few moments to move on to our next polling question as we start to wrap up. Really what we're kind of looking for is your general impression on how helpful the information presented was today. So I will leave that open as we move forward and go back to the chat section. We do have a question in here. So do you know, Anna, if there were many subjects with higher BMI, so class 3 or above 40 that were included in the studies reviewed, or were the subjects mostly in the overweight or class 1 category?
Yeah, actually, so what we looked at was all of them were from the overweight onwards, but yeah, there were some studies that were specifically looking at obese adults, and for my PhD, for example, I looked at obese adults, and I think our rationale behind that was that in terms of England and the NHS, it's unlikely that you would receive a lot of treatment if you're classified in the overweight group. So we wanted to look at people that were actually getting treated by the dietitians or exercise experts in real life. So we tended to sway more towards the obese, so BMI over 30. But yeah, there were some studies within the review, but I think it was more of a mixture. There were some studies that just used the definition overweight or obese. But the majority of the studies, the mean average for the BMI was more towards the 30 region.
That's very interesting. Thank you for sharing those details. So as more questions might come in, another thing that I was kind of interested in hearing from you is really how did you go about, I guess, selecting your outcome measures? So I know that with weight loss, waist circumference, BMI change, and 5% weight loss, are those, what kind of process did you use to select and prioritize those as your outcomes?
Yep. So the reason, so I mentioned so for our national guidelines, the recommendation is that participants should lose 5% of their initial body weight as a way of providing beneficial health implications. And so we from the start knew that that was one of the key ones that we wanted to introduce. Weight loss is one that is very popularly collected in weight loss intervention, and as we identified in the systematic review, it did tend to be the majority of the times the main outcome measure. So it did involve a little bit of scoping to see what was actually collected, because I think that's important before you set out and do a systematic review, is actually see what available data there is. Because in terms of things like I've mentioned, like diet and physical activity data aren't necessarily always reported within papers. BMI change and waist circumference. So BMI change we thought was important because that was one of the criteria that we were looking at participants with. And for the waist circumference, it's been found that reduction in waist circumference can have beneficial impacts on health. So we thought that was another important one to look at. But I think it's important not to look at too many different outcomes because you do tend to get a lot of data in a systematic review as well. So we tried to keep it to those 4 key things.
Thank you. Yes, I guess it is very important to have the data, I think, to look at as well.
Yeah.
Absolutely. So at this point in the presentation, please feel free to continue posting questions. But we'd like to just also share a few options for ways that you can interact with health evidence moving forward. So these would include visiting our website, registering to receive our monthly tailored registry updates and or the monthly newsletter to stay up to date on new research and upcoming events, including future webinars, to tell your colleagues about healthevidence.org. You can also follow us on Twitter using the @healthevidence handle. And we encourage you and your organization to use health evidence to search for review-level evidence and in order to help inform program planning and policy decisions. As well as, please feel free to contact us to suggest future topics for webinars that you might be interested in, or to provide feedback on the series. So with these potential actions in mind, we'd like to get your thoughts and have our final polling question on what are your next steps after learning about this review-level research on internet-delivered interventions providing personalized feedback for weight loss in overweight and obese adults. So whether or not you plan to access the full systematic review once this webinar is over, access the quality assessment for the review that's on healthevidence.org, consider using the evidence, or tell a colleague about the evidence and the results that you learned here today. So I'll just give a few moments for people to be responding, but it does look across the board that many people are planning on accessing the systematic review that Anna presented here today, as well as the quality assessment, and a few is also telling a colleague about the systematic review and considering using the evidence. So that's really great. So I guess in the interest of time, I think this brings us to the end of our question period and very much close to the end of our time. So I would like to give a very big thank you to our presenter, Dr. Anna Haste, as well as to our audience today for posting questions and making this an engaging and stimulating session. One final reminder that the copy of the recording of this webinar and the PowerPoint presentation will be posted online in the next week or so. Those will be available on our YouTube and SlideShare accounts. So thank you very much, everybody, for joining us today. And Anna, I don't know if you have any final words that you'd like to share?
No, I think I've covered it all already. Thank you. Thank you for asking me to speak.
Yes, no, thank you so much. And we really appreciate you coming in, especially, I guess, with the bit of a different time difference. So thank you for taking time this afternoon to join us. We really appreciate it. And thank you, everybody, again. I wish you all a good afternoon.